Good afternoon, everyone. Thank you, Charles, for inviting me to speak to you. Hopefully, the information that I'll present will be useful, and you'll find out why, because it's quite hard to do this within 15 minutes, because I usually provide training for about 2 hours at our district, and some training is half a day or whole day. And that's due to the diversity that we have in New South Wales as well as our district. And what I understand, your district is similar to ours when it comes to population. You've got high levels of diversity within your district, but smaller numbers, which makes our job much, much harder. So let's try to do this after a wonderful lunch. Hopefully I don't fall asleep. So palliative care, I won't go through the definitions. I think the speakers prior to me have used it. It is all about people-centered or patient-centered health services and practices that we do. When it comes to cultural linguistically diverse, and I do pronounce it as cald because it means warm in Italian, because I can't hear the difference to this day between cald and cold. We're not cold, we just don't speak the language. So it is reviving serious health-related suffering, be it physical, psychological, social, or spiritual, and it's a global ethical responsibility for all to receive. Now, a little bit about our state, because I do not have your numbers. I do have our numbers. For example, at Nepean Blue Mountains LHD, that is similar to this one, we have people from 165 different countries of birth, speaking 150 languages, and with every religion that you can think of. So, when it comes to our state, we're the most diverse state on the globe. There are 2.8 million people who now call New South Wales home. We're born outside of Australia in more than 250 countries. Sorry, I'm trying to look at that in here. 250 countries, and 2.2 million of us speak a language other than English at home. For example, I speak 6 languages, which is normal, where I've grown up in Sydney, which is Eastwood. But there's more clinicians, more health professionals that do have those bilingual, multilingual skills that are underused. And I'll tell you a little bit about the policies, and some of you might be happy that those skills should be used and are preferred option rather than interpreters. Okay, so now what is cultural competency? I'm assuming most of you have seen this. This is one of the definitions that we do use across the state when it comes to multicultural health services. It's at the core of high quality, patient or family-centered care, and it directly impacts how care is delivered and received. Means developing attitudes, skills, and levels of awareness to provide culturally appropriate interventions. Requires great sensitivity and effective communication, either by interpreters or without using interpreters if they do speak English, but be wary when we do learn how to speak English. We still speak English the way we speak our language. You'll notice my hands going everywhere, and I do speak directly. Not that I'm not polite, it's just the way we speak two of the languages that I grew up with. Now, cultural responsiveness, it is person-centeredness, encompasses qualities of compassion, empathy, and responsiveness to the needs, values, and expressed preferences of the individuals. Culturally responsive care respects diversity of the patient's unique cultural and linguistic needs to provide high-quality care and improve health outcomes. Diverse CAL groups may be encountered in health services, and some principles to consider on cultural competence are trust, language, family dynamics, traditions, customs, and spirituality. And how do you do this well when you have people of 165 countries of birth coming to your services? Are you going to get it wrong? Of course you are. It's about finding the golden middle in between us as healthcare providers as well as who they are. Please do not assume that you know. As mentioned, I am from Bosnia. I came here as a refugee. The next person, and I know my community lives in this area as well, won't be this tall, won't be mixed Austrian, Croatian, and Bosnian, and won't even speak or look like I. So please don't assume. Whatever I say, it is true for my family where I'm from, but might not be for the family that you're seeing. Now, why do we need to do this? For those that are in health services, there's quite a lot of policies, standards, and professional standards that we have to follow. But do we do well? That's another question. We all provide a lot of training how to be culturally responsive. People tend to invite me quite a lot. I think they love my accent. But it is about how do you apply all of that? And how well are we doing after we do provide the training? It is about application and thinking about how to improve. 2 seconds. Now, sociocultural background, I will give you some lovely examples soon. Let's go through the theory, the boring bit first. So, sociocultural background can influence consumers or client or patient's perspective, values, beliefs, and behaviors regarding health, well-being, and end of life. The consumer's perspective may impact on health-related behaviors. For example, these factors may give rise of variation in symptoms expression, thresholds for seeking care, comprehension of management, strategies, and expectations of care. What do we expect from you? Now, please be aware, I know we're supposed to be working with patients and come to the inclusions. Patients or consumers or carers are supposed to be partners in the care we deliver. For the 95% of CAL population, if you are to ask them, what do you think? Our answer will be, I need a new doctor. Why would you ask me? Because you're the doctor. We do put doctors and nurses on pedestal, regardless how long we're here, but we find that culturally quite inappropriate sort of question. You can still ask the question, but maybe going around and trying to find a little bit more and giving them options with the reasons why you're giving those to them, and sort of checking in, which one would you like? This is what is going to happen if you do A, and this is what's going to happen if you do B. But most of us tend to do quite a lot of nodding across different countries, because you know better. You went to uni, not me. So just be aware. Nodding can mean two things. One is, yes, yes, I want you to go away. Stop asking. Other one can be that I don't understand what you're saying. And that's another thing to consider. For example, in our district, we have a large Maltese, German, Polish, Greek, and Dutch community that is getting older. They do speak English, but they speak basic English. I'm not saying basic English or English that they needed to speak for the jobs that they did. So when it comes to the health terminology, they wouldn't have a clue what they are in their language, let alone in English. So just be aware how you are explaining things. Please try to use plain English and shorter sentences because of the anxiety levels. You can tell by me now, is it German going to come out or Croatian next? It's the lunch, I tell you. Now, identifying cultural and spiritual needs that inform end-of-life care. Now, unfortunately, there's no such a thing as a cheat sheet. You will find a lot of resources available that say if someone is of Islamic faith, Hindu, Sikh faith, these are the rituals they follow. This is what bereavement is supposed to look like. Please read that before you see the patient. It gives you a bit of a hint, but don't assume it's going to be that way. Because religion is practiced within a family. It's practiced within a country. For example, if we take Islam as a religion, there's people who are Muslims in Indonesia, Middle East, Turkey, even Europe. And they follow it differently because there's a lot of customs. So the best thing is ask. Another thing is asking appropriate questions where the person is from. Don't ask only the country where they're from. Ask for the city, ask for the region. Because there are differences. Like, for example, in our district, someone from Penrith is different to someone from Lithgow. There are cultural differences, even language differences, how they express themselves. Now, there's also differences when it comes to understanding of health. For those that came to Australia like me, we don't get a brochure, not in English, not in any other language, saying, this is how your health system works, education, police. So what happens is, when we don't have that information, we assume it's the same as back home. Now, palliative care, I'll be happy to say, has started in Croatia. In Bosnia, they're still struggling to find funding for something called palliative care, but a lot of countries don't have this as a service. So people tend to take care of their loved ones, either at home. For some cultures, is hospital. That's all that is culturally appropriate. Yeah. Now, how do we incorporate all of this? So, with the religion, as I said, be wary and ask how it's practiced and when it's practiced. Also, don't ask everyone about their religion unless they tell you. Because there is a group that could be non-religious, atheists, and the services that you offer, be careful that are not sort of associated with religion. And same goes when you're offering services such as, for example, support if there's a financial, if they're struggling financially, they need support with the food. Don't send a family, let's say, that arrived 2 years ago from Syria as a refugee to Salvation Army. Even though they might have, and they do have, halal things for them to use, it is culturally inappropriate. Yeah. Now, general belongings, please be aware that in a lot of cult patients, this is quite important. What is left on their hands? When the person passes away, whether or not the prayer needs to be performed. For example, I know with our Turkish community, it is when the person passes away for the family member of the same gender to get it could be community leaders to wash the body before it's taken away. So just be wary. Some, for example, for Sikh community that I work with, what they're wearing needs to stay on, like their shorts, like their sword. So ask the family. Now, extended family, it could be great, you know, when you're looking after the patient, but it also could produce problems. Now, some communities do say you're not supposed to tell the patient that they're dying. In some religions, some cultural backgrounds. Now, if a person doesn't speak the language, and 9 out of 10 times that I have witnessed, because I do help our palliative care, the person already knows. But please try to speak to the person using interpreters to the patient, because what often happens, patient feels as if they're that child, 2-year-old if they're older. Because people often talk to the family. Do not use families and interpreters either, please. As I mentioned, use interpreters. I think the best practice would be using bilingual, multilingual, medical officer or nurse. And that is supported by our interpreter policy, so you're allowed even to take consents in other languages. Now, before I finish, and hopefully I've got a couple of minutes left, recently, I just want to let you know, recently we had a wonderful consultation with cult communities in our region. It happened on the 1st of May and 22nd of May. It was the hardest consultation for me to organize, and I've been doing this for 16 years, and Emma can tell you as well as Dave, I call people, they come. We don't even need to advertise too much. 100, 200 people that we will have next week for Refugee Week, for example. But this one was the hardest one to organize because it's culturally inappropriate to talk about that. It could jinx you. It could bring bad luck onto your family. And this is from cultures from Europe down and South America as well. I think we were fortunate that some of them did see, you know, the catering will be provided. So if you are inviting cult communities, make sure catering is provided. Make sure the food is culturally appropriate as well. So we had 22 consumers from Afghanistan, Iran, Malta, Greece, Croatia, Fiji, Samoa, and Cook Islands, I think. I might have missed 2. And this is what they had told us, because we are currently building a new palliative care ward in Nepean Hospital. They've highlighted the importance of communication and preparation. And it was one of the things, talk to me, don't talk to my child. Involve me into the discussion. The support needed for carers and families, what happens when they're gone. And I do have a wonderful resource for you at the end. Please refer them to Transcultural Mental Health Line. It's a free service, counselling available in over 65 languages, and they can call themselves. Providing patient-centered care to be more of a family-centered care. In some cultures, the death is celebrated, so to say, like in some Pacifica cultures. In some, it's 40 days of mourning, and the things that need to happen after the person passes. No. So they also told us, or informed us, that we need to get better at cultural sensitivity and cultural communication and normalize end-of-life discussion. One surprising thing from this consultation was that wonderful palliative care unit, as well as advanced planning care coordinator, were invited to speak at our Refugee Week event, which is quite odd. So they made an impression. So if you are meeting CULT communities, make sure that you sort of give yourself time to go to the next event. They like to see the person face to face. We don't do well with, yes, call this number, someone will answer. We need to know the person. We need to sort of see them and build that trust. And unfortunately for you, like for us at Nepean, none of the community leaders or community members are Googleable. So it's basically to establish the trust, you need to be out there. So there's some lovely photos from our consultation. Now the resources, if you remember anything from today, please remember this slide. It does work with CULT and non-CULT patients. It does look simple and common sense, but often is not done too well. And please use the teach-back technique. It started with CULT communities about 11 years ago. Now it has picked up with all the other communities. So here are some of the resources. If you don't know your multicultural health service and a wonderful manager called Ashley Young, please send him an email. Please ask him for support, because he would know where your communities are, who the community leaders are. Also, talking to your migrant resource center, and this is the only one I could find for your district. If you need resources in other languages, you can download them for free from New South Wales Multicultural Health Communication. It has a resource absolutely on everything and anything you need. I've also attached What Matters in the End, a new report, research report from Western Sydney. I think that will be shared. And Transcultural Mental Health Line. Please do promote it, especially for communities in your region and my region, where there's no too many bilingual allied health workers or bilingual GPs. We tend to travel for GPs. We even wait for our GPs. I know for my community, people line up at 6 a.m. in Liverpool for Dr. Tomasevic, and he opens at 8 o'clock. So just be aware of that, and when you ask a person for a GP, ask where they're based as well, because you will be surprised that the people will travel. I think, is that it? Yeah?
Thank you so much, Una. Please join me in thanking Una. Quick question, how many of you in the audience speak a language other than English? I'm curious. Okay, interesting.
Yes, and very useful
And
for our patients.
Yeah. Thank you for all the resources, and also for calling out Ashley Young, who I know would be very delighted to have his name splashed about. He'd love to hear from anyone in this room. Do any of you have questions for Una? We have time for maybe one, maybe two.
Just a question.
Yeah.
We've all done in health the various called, got to do the training. Is there a training available that's specific for palliative and end-of-life care that's culturally appropriate?
There is for the health workers, who work in LHD. We did sort of develop a 20-minute CALD-specific palliative care training for the state. I was part of that. There's a number of videos in there as well. It's a great start, but what it would be better is getting appropriate training for 2 to 3 hours, like our district trialed about 2 years ago, and they keep on calling me back. I don't know why, but I think more face-to-face training for things like that, because you can ask. If it is online, we can't tell you everything. I know in our palliative care, I've been supporting patients from 5 different cultural backgrounds, and they all had different issues. From, trying to take the body overseas and not telling the palliative care, and everything that actually resulted after that. It took them a month and a half for burial to happen in Greece. From people, when they find out that they don't have too long to live and they end up in palliative care wanting to go back home and die. Or, people that are here on their own. Like I think last patient was a German background patient who had no one here, lived here 38 years, and then finding his family overseas, who sort of moved to Greece from Germany. It is a challenge. So it does present with a lot of different challenges. And that you would get out of face-to-face training. Because we all sort of forget and then remember as we go. That was supposed to be in one of the slides, I forgot. Thank you.
Thank you very much, Una.
Thank you.